Endometritis is an inflammatory condition of the endometrium, the inner lining of the uterus. With profound implications for women's reproductive health, this condition can manifest as acute or chronic, each with distinct etiologies and clinical profiles. Acute endometritis often arises postpartum, particularly after cesarean sections, affecting up to 30% of women with recurrent pregnancy loss, while chronic cases are subtler, linked to infertility and plasma cell infiltration and stroma. As we explore this topic, we'll examine its epidemiology, including its prevalence in postpartum settings, its infectious causes tied to ascending bacteria, and risking factors like obstetric procedures. We'll also cover its diagnostic challenges, treatment strategies such as broad spectrum antibiotics, and research into endometrial microbiomes. Now that we've introduced endometritis, let's explore how widespread this condition is in the population. Chronic endometritis affects about 30% of women with recurrent pregnancy loss, while postpartum endometritis occurs in 3 to 20% of childbirth cases, rising to 40 to 54% with inflammatory complications. Cesarean deliveries heighten the risk 5 to 20 times compared to vaginal births, driven by increased bacterial exposure. Adolescents also face elevated rates with 16 to 20% of pelvic inflammatory disease cases linked to this age group. These figures exemplify endometritis as a prevalent gynecological concern shaped by delivery methods, age, and reproductive history. With these causes in mind, endometritis manifests in various forms, primarily from bacterial ascension from lower genital tract into the uterus. Key risk factors include cesarean sections, obstetric procedures like hysteroscopy and uterine curettage, and prolonged labor or rupture of membranes. Piercing and Sethi, multiple vaginal examinations, retained placental tissue, sexually transmitted infections, and intrauterine devices also elevate risk. In developing regions, chronic conditions like tuberculosis also play a high role. Commonly isolated organisms include Streptococcus species, E. coli, and anaerobic bacteria. Highlight the infectious basis of this condition across its acute and chronic presentations. Building on its etiology, endometritis is classified into two primary types. Acute endometritis features a rapid onset, often tied to postpartum or post-procedural infections, presenting with fever, pelvic pain, and purulent vaginal discharge. In contrast, chronic endometritis is a persistent, often asymptomatic condition marked by plasma cells in the endometrial stroma, commonly linked to infertility and recurrent pregnancy loss. Beyond these, specific forms like tuberculous endometritis and puerperal endometritis emerge, distinguished by their unique causes and clinical context, reflecting the diverse manifestations of this inflammatory condition. Now that we've classified endometritis, let's explore its clinical presentation, which varies by type. Acute endometritis presents with fever, pelvic pain or discomfort, purulent or foul-smelling vaginal discharge, uterine tenderness, abdominal pain, distension, and abnormal bleeding. Chronic endometritis, often silent, may be asymptomatic or show subtle signs like abnormal uterine bleeding, pelvic discomfort, dyspareunia, leukorrhea, and infertility, which is linked to repeated miscarriages or implantation failure. Notably, chronic cases are frequently uncovered during infertility or recurrent pregnancy loss evaluations. Per McQueen, this can lead to diagnostic challenges. While these symptoms guide us, understanding endometritis pathology via ultrasound is key for diagnosis. In acute cases, ultrasound may show a thickened, heterogeneous endometrium with fluid or gas, suggesting inflammation. Chronic endometritis often presents with a persistently thickened lining, irregular echogenicity, or subtle endometrial irregularities reflecting stromal changes. Per Taylor, in tuberculous endometritis, calcifications or adhesions might be visible. These ultrasound findings highlight inflammatory disruption of the endometrium, potentially affecting implantation in early pregnancy, and offer a non-invasive window into the condition's impact. Building on ultrasound insights like a thickened endometrium or fluid in the cavity seen on transvaginal ultrasound, laboratory tests refine endometritis diagnosis. In acute cases, a complete blood count shows elevated white blood cells and C-reactive protein rises with inflammation. Per Voot Jovanik, For chronic endometritis, endometrial biopsy is the gold standard, supported by histopathological examination and CD138 staining to detect plasma cells. Microbiological cultures identify causative organisms, while PCR targets specific pathogens like Mycobacterium tuberculosis. These tests, paired with clinical assessment, confirm the condition's inflammatory basis. Given the laboratory findings, distinguishing endometritis from similar conditions is critical for effective management. Its symptoms overlap with endometriosis, adenomyosis, pelvic inflammatory disease, ectopic pregnancy, ovarian cysts or tumors, uterine fibroids, endometrial hyperplasia, or cancer, cervicitis, urinary tract infections, and in acute cases, appendicitis. Each requires careful differentiation. Endometriosis may show implants on imaging, while adenomyosis alters uterine texture. Clinical evaluation alongside imaging and lab tests ensures accurate diagnosis, guiding tailored treatment and avoiding mismanagement of these diverse pelvic pathologies. Once differentiated and diagnosed, endometritis treatment varies by type and severity. For acute cases, broad-spectrum antibiotics like clindamycin plus gentamicin are standard alongside supportive care with hydration and pain management. Chronic endometritis requires targeted antibiotics based on culture results, often starting with doxycycline empirically, and addresses underlying causes such as removing retained products of conception. Tuberculous endometritis demands anti-tubercular therapy. Follow-up biopsies may confirm resolution in chronic cases, while refractory situations might involve hysteroscopy or immunomodulatory therapies to restore endometrial health. While treatment is often effective, untreated or poorly managed endometritis can lead to serious complications. These include infertility, recurrent pregnancy loss, and preterm birth, alongside progression to pelvic inflammatory disease or tubo-ovarian abscess. In severe acute cases, sepsis poses a life-threatening risk. Chronic issues like Asherman syndrome with intrauterine adhesions, chronic pelvic pain, ectopic pregnancy, and a heightened endometrial cancer risk may also emerge. Early diagnosis and proper treatment are essential to mitigate these outcomes and preserve reproductive health. Understanding these complications highlights the value of timely treatment and its effect on prognosis. Per Terglosa, acute endometritis typically resolves within 2 to 3 days of antibiotic therapy, with most patients recovering fully. Chronic endometriosis boasts a 60 to 94% cure rate after one antibiotic course, and successful treatment boosts live birth rates in women with recurrent pregnancy loss. Yet some face recurrent endometritis or complications like infertility or chronic pelvic pain. With proper management, long-term prognosis is generally favorable, though ongoing monitoring may be needed for recurrent or complex cases. With prognosis tied to timely intervention, advancing our grasp of endometritis fuels better diagnosis and treatment. Current research, including work by Singh, McQueen, and Terglosa, explores improved diagnostics via novel biomarkers and imaging. The endometrial microbiome role in health and disease and chronic endometritis linked to infertility. Efforts also target therapies for antibiotic-resistant cases, immunomodulatory approaches, and long-term reproductive outcomes. Future directions include probiotics for prevention and treatment, plus strategies to curb postpartum endometritis in high-risk groups, promising enhanced reproductive care. As we conclude our scientific exploration of endometritis, let's align this medical knowledge with a biblical perspective. Scripture reminds us to care for our bodies, as seen in 1 Corinthians chapter 6, verses 19 to 20. Or do you not know that your body is a temple of the Holy Spirit within you, whom you have from God? You are not your own, for you were bought with a price. So glorify God in your body. This is a call to stewardship, which encourages early diagnosis and treatment, reflecting God's design for health and healing in both physical and spiritual feelings. In conclusion, endometritis remains a significant challenge in gynecology. Accurate diagnosis, timely treatment, and ongoing research are crucial for improving outcomes and advancing our understanding of this complex condition.